Hello everyone, this is Shad Race from SCAI 2024. I'm really privileged to be with Dr. Serdar Farhan, who presented the late breaker at SCAI 2024. Thanks for being with us, Serdar.
Thank you for having me today.
Yeah. So you presented your late breaker trial for peripheral artery disease, FIMPOP disease, differences in revascularization. Can you walk us through the background?
So the idea of this sub-analysis of the REVIVE study, we called this patient-level pooled analysis REVIVE. The acronym stands for Revascularization Strategies in Patients with Femoral-Popliteal Artery Disease. And this sex-specific sub-study is targeting to investigate the outcomes and compare actually the outcomes with different revascularization strategies, meaning endovascular therapy with a stent implantation as compared to bypass surgery with use of autologous venous graft or prosthetic graft material. And we wanted to compare whether there are differences by sex with applying different revascularization strategies.
So it's an age-certified analysis?
It's a sex-specific analysis.
So it's a sex-specific analysis and also strategy analysis?
Strategy analysis,
yeah. Interesting.
So the initial analysis, which we published last year in JACC, showed that after 2 years, endovascular therapy with a stent implantation had comparable outcomes with regards to major adverse limb events, comparable outcomes with regards to amputation-free survival. The individual components of the major adverse limb events were also comparable. And the early safety outcome, which was defined as any bleeding, infection, or all-cause mortality within 30 days after the procedure or surgery, was in favor of endovascular therapy with stent implantation. Hospital length of stay was also significantly lower in the endovascular therapy arm. And in this analysis, we aim to compare females and males separate, and in each stratum the revascularization strategy.
Yeah. So let's talk maybe about first the outcome of female compared to male, with the endovascular outcome.
So this study was not targeting mainly to compare females with males, but if we see males and females, they had comparable baseline and procedural characteristics, because the studies which were included in REVIVE were all randomized fashion, so the patient's characteristics were comparable. In the female patient population were a little bit more claudicants than critical limb ischemia than in the male arm. With regards to the procedure itself, also no major differences. We saw that, and this is also from the primary analysis, evident that technical failures appeared only in the endovascular therapy arm as compared to surgery, and this was lower in the female patient population than in the male patient population.
Interesting. How about the surgical outcome?
The surgical outcome, so this sex-specific analysis showed that after doing endovascular therapy with stent implantation as compared to bypass surgery, in women and in men, had similar outcomes with regards to major adverse limb events. Amputation-free survival was also comparable between surgery and endovascular therapy in each sex-specific subarm. The individual components of the primary endpoint were also comparable. And now comes the safety endpoint, which was again the early complications defined as any bleeding, infection, or all-cause mortality were significantly lower in both endovascular treatment arms as compared to bypass in both sexes.
So if we look at the log rank between all four, so which one is the best outcome and which one is the lowest outcome?
I mean, this is it's hard to compare, because I mean there is a log rank between all groups, which is not significant.
I see.
But
which is good,
interestingly, we see, and this is something where PAD is a little bit needs a little bit more work and more further studies in the future, especially that major adverse limb events occur in up to 35 to 42% of the patient population, regardless of sex and regardless of the revascularization strategy. Even though there is no difference between revascularization strategy, it means that we still have to apply much more work and do further investigations to see how we can reduce these events in the future. Mainly not only by the revascularization strategy, also by medical management and improvement of the guideline-directed medical approach for patients with PAD.
Absolutely. So final question from the initial trials, how many females and males enrolled in the trial?
So that's a very good question. Again, as in the major flag of our analysis is that women are underrepresented in clinical trials, especially in PAD. Pooling our data from the 5 randomized clinical trials, we had 29% females.
Which is usually about 30%.
It's about 30%. Yeah, it's also underrepresented, but this were like a retrospective pooling of those randomized clinical trials. I think future trials should address more active enrollment of women to be able to provide more evidence and more granularity on which revascularization strategy is the most optimal one. What we saw strikingly in this REVIVE sub-analysis is that comparing women undergoing endovascular as compared to bypass, there is 2/3 more bleeding risk in the early phase in women as compared in women with bypass surgery as compared to endovascular therapy. In the male sub-arm, we see just half of that. So women appear to be in particular prone to bleeding, and maybe endovascular therapy with a stent implantation might be of benefit for women. But future trials should address this with a higher patient population and more robust prospective
endpoint definition,
and CEC adjudication.
Absolutely, yeah. Well, thank you so much, Sardar, for your time. Congratulations for being selected as a later breaker presenter. Watch these videos and others on SCAI-TV. This is Shadi Reis from Long Beach with SCAI 2024. Thank you so much.
Thank you very much.